Welcome to a live chat with Nurse Linda. Today's topic is how the nervous system makes the body work. Linda Schultz is a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher and Dana Reeve Foundation for close to 2 decades. Now I'm going to turn it over to Linda. Hi, Linda.
Hi, and thank you. Welcome to my home. Here we are again. Still in the house, still housebound, but that's okay because things are improving out there. We're getting closer to our vaccine relief, and so that's great. I did want to talk just a moment about a little bit about the vaccine because I attended the Christopher and Dana Reeve Paralysis Foundation advocacy webinar yesterday, which was really interesting and informative. If you have a chance, you can go back and listen to that recorded information. It was really helpful to understand how you can help move research forward and help get the political climate more organized towards favorability for people with all sorts of differing abilities. So it was really a very informative way to get involved. You don't have to like jump in and be like the end all be all advocate all at once, but it kind of helps you, set the stage and maybe think about some things you'd like to do. But one of the questions was about the vaccine, and that was, does spinal cord injury qualify you to move up on the list? And yes, spinal cord injury is a disease that's classified as an immunosuppressant disease because that pesky autonomic nervous system does not always respond to a bacteria or virus in your body as quickly as it should or as it could, or it might not even respond at all. So you do classify as immunocompromised. So that certainly moves you up the list. If you were not aware of that, I want you to be sure and know that because you can get your vaccine maybe a little bit earlier. And it's important. And not only with spinal cord injury, but if you have any kind of neurological disease. So if you had a stroke or if you have MS, or if you have just about any neurological disease, that will shoot you right into the immunocompromised area. Now, last month, I also talked about the news had come out about people who were getting the vaccine who had those facial fillers put in. And they were having some reaction to that because the vaccine noted that that was something abnormal, not, human made in the body. And so it was kind of attacking people who had facial filters where their filters were. And so the question came up, what about Botox? Would that work the same? So I've been looking for research about that. And as you know, there's not a lot of research about various specific little kind of individual things about the vaccine and different things like Botox. So Botox is a different sort of thing, whereas those fillers are some substance that gets injected in your face. It becomes rather rigid and it stays like a little blob there. And the Botox is botulinum toxin that's injected. Now, some people get Botox in their face, much, much smaller dose, like 1 to 2 cc's, versus what you might get in your legs for spasticity reduction. And that would be like, maybe I've seen people have like 4 bottles injected into different spots in their legs. So it's a lot different amount, but it works a lot differently as well because that goes into the muscle and it spreads throughout the muscle. So it's not this clump of isolated something that's laying up in under your skin. So the scientific reports are that it has not been found to have any contraindication with the COVID vaccine. However, it has not been particularly studied. It just hasn't been that people have reported that they had the Botox and then they had a problem with the vaccine. Now, the vaccine's been given to thousands, well, millions of people. So if there was an issue, I would think a report would have come up about this, but so far not. And physiologically, it doesn't make sense that it would cause trouble, but then who would have ever guessed about the facial fillers either? So there are a lot of things out there that we don't know about the vaccine, but we do know one thing is that it's very effective against getting COVID. So when we look at our risk versus benefit, we think about the risk of getting COVID and dying with a poor immune system versus having the vaccine, and the side effects of the vaccine have really been minimal. It's really kind of amazing, and that is because of this mRNA that they're doing. It's a new technique for a vaccine, but it's been studied for at least 40 years. So we're not talking about like this is something that's so new and novel that we don't really have any idea. Yes, we do. They just needed to get some virus to point the vaccine towards, which was the COVID. And so it's really working out to our benefit. So that's great. So now just because you get the vaccine does not mean you need to let down your guard in any way, shape, or form. Um, One of the big misunderstandings about vaccines is that it eliminates the virus. Vaccines don't eliminate the virus. Okay. So if you think about the polio vaccine, it keeps polio from traveling throughout your body, but it doesn't eliminate the virus. It's still out there in the world. People still get polio because so many people have been vaccinated against it. It doesn't come up very much. Polio doesn't come up as a diagnosis, but the virus is still out there. A more recent one is measles, and a lot of people have been vaccinated against the measles. And so a lot of people said, well, we don't need to be vaccinate our children against measles anymore because the virus has been eradicated by the vaccine. Not true. As you know, there's a lot of people who are against vaccines. That's, they're right. So they're not having their children vaccinated against the measles, and the measles outbreaks, we hear about them all the time at various different times in the news where measles pops up in a big community and there's a huge outbreak of it. It's a very serious, measles is a very serious disease with horrific consequences. So it doesn't the vaccine won't eradicate the virus. It just keeps it from entering the cells of our body. If it can't enter the cells of our body, it can't replicate. And so therefore we don't get sick with it. So with the vaccine, you do need 2 doses with the Moderna and the Pfizer. Those are the vaccines that are out now, and you need 2 doses. They should be 2 doses of the same vaccine. So you shouldn't have one of one kind and one of the other kind. Now, there's some research that's being done on that. There's some thought that it won't matter, but what we know right now today is you should get the same vaccine. The first dose should be the same as the second dose. Okay, so there's going to be some cases where that's not going to be possible. That's nothing to panic about. But right now, today, that's what we know should happen. It could be announced on the TV right now that that's, completely off base, but that's what we know right now. After the first shot, you have a 50%, they're calculating a 50% immunity. Again, that whole immunity thing has not been studied because it hasn't been out long enough. So they don't have sufficient numbers, but they are studying it. And they think it's about a 50% immunity. Now, 50% is half. A whole percentage is 100%. 110% is a colloquialism. You can't have 110%. 100 is the maximum. So if you have 50%, you have a 50-50 chance that you could have the COVID enter your body after the first vaccine. So you don't want to give up your precautions, your mask, your hand washing, your social distancing. You don't want to give up any of that. Now, with the Pfizer shot, in 21 days, you get the second shot. And with the Moderna vaccine, in 28 days, you get the second shot. When you have the second shot, after the second shot in 2 weeks, you'll have a 95% immunity rate. That means you have 95% chance that you will not get the COVID. You have a 5% chance that you can still get it. The thought is, even after the one shot, but especially after the second shot, if you would get it, you won't have such a severe case, and your risk of dying is supposedly to go down. So that is all good news. So lots of good reasons to have it. Now, you still will want to keep up those precautions. And the reason is because right now the COVID virus is so heavy in our community. When the people study infections in people, they talk about the viral load inside your body. How bad is the infection depends on how much virus you have in your body, and it's called the viral load. But there's also another viral load, and that's the viral load out in the community. So right now, the viral load in the community is extremely high. Your chances of getting it are high. As the viral load goes down in the community, as more and more people get vaccinated, the chance of that 5% chance will still be 5%, but you won't have the exposure like you do with the viral load now. And the viral load actually is going down across the United States right now. Not enough that it makes a difference that we can stop our precautions. A side effect of the precautions that we have taken is that the flu has gone down so very, very much. There's been hardly any flu recorded compared to usual years, and that's because people are washing their hands, keeping their distance, they're wearing their mask. Mask is very important. They're saying now because of the new strains, perhaps you should be wearing 2 masks. You can wear a mask with a filter, which means you can take, well, I prefer coffee filters. Just fold it in half. I put it inside my mask and then I secure my mask around my face. Another thing you could use are those really cheap napkins. And the reason why is because these are pressed paper, so they don't have a lot of fiber. They don't have a lot of fiber. If you look at your paper towel, it has a lot of loose fiber that can come off of it. Toilet paper has even more loose fiber. You don't want to be breathing those fibers in. So if you use something like a coffee filter or the really cheapy napkins, you know, the kind you get at the fast food place where you wipe your hands with them and there's just a big grease stain on there because it can't absorb that. Those are the best kind. If you take your mask and hold it up to a light, if there's light coming through the mask, that means that the virus can come in. So how big is that virus? Well, you know, I'm like a dog with a bone in this stuff. I've just got to know everything about everything. So if you would take one strand of your hair, and you know how tiny that strand of your hair is, and if you would line up the COVID virus to go across your hair, not the length of your hair, but just across the diameter of one strand of hair, 150,000 COVID viruses could line up across the strand of your hair. Oh my gosh, that is a tiny virus, as they all pretty much are. So that's what I want to say about the virus. Just be careful and be cautious. It's real easy to think, oh, well, we're so far out, or I've got my first shot, or I've got my second shot, and so now I'm well protected. No, we still have to watch that viral load in the community. We still have to be careful. But the point of today's webinar is to talk about those motor neurons. And it's very physiological. There's a lot of things, you know, the nervous system is so complicated. That's why I love it, because there's always something new to learn about it. But people have different issues with their paralysis. They, especially with motor problems. And this can be with spinal cord injury. It can be with a head injury. It can be with stroke. It can be with multiple sclerosis. People who have multiple sclerosis have more difficulty with movement because of the plaques on the spinal cord, not so much the plaques on the brain. It's kind of an interesting thing. So there are a lot of neurological diseases, you know, that all fit together in different ways. So when a person has, I'm going to go with spinal cord because that is the simplest breakdown, but we'll add in others as we go. So there's really 2 different kinds of injuries in the spinal cord. One is called the upper motor and one is called the lower motor. And because upper motor neuron injury usually goes with cervical and thoracic, that's the vertebrae of the spine that are connected to the ribs. Those are the thoracic vertebrae. Because the upper motor neuron injury usually follows those. We kind of classify it that way. And then the lower motor neuron are the lumbar and the small of the back, and then the very end and the sacral spinal cord. And those are the lower motor neuron injuries, but it's really not quite that simple. So what happens is the body senses things, and those come from the sensory nerves that are in our skin, they're in our fingertips, they're everywhere in our body. And then they're also inside our bodies. So like if you get a stomach ache or you have a little cramp in your side or something's going on, all that is controlled by sensory nerves. Those nerves send messages to the brain. Those send up to the brain. And it all happens so fast. That's what's so incredible about it. So once that message gets sent, it could be that, oh, something feels really good. I've gone outside and the sun's hitting on my skin and it feels wonderful. It can be a pleasurable feeling, or it can be harmful feeling, like I got my hand too close to the stove and whoop, I pull it away right away because my body has responded, you're going to get burned, so stop doing that. It can be pain from neuropathic pains, spasticity, or it can be, hey, everything's going just fine. We don't need to adjust anything. It's constantly giving your brain this feedback for everything that's going on in your body. Those are what the sensory nerves do. Now, the motor nerves take the message from the brain that says, go into action. We need to do something. So when you get too close to that stove and your finger, whoop, there it is, senses heat on the end of your finger, you pull it away. Those are the motor nerves that are making you pull it away right away. The motor nerves have the upper motor and the lower motor neurons. Neurons are another word for nerves. So in the upper motor neurons, in the cervical and thoracic area, those originate, the body of those nerve cells are actually in your brain. Some are nerve cells have that really one long arm that shoots out from the nerve. That's called the axon. It has some smaller sproutings. Those are called dendrites. The axon is the one that transmits messages across. The smaller ones do their work too in this process, but I'm just going to try to make it just as rudimentary as possible. So when the motor nerves, which are attached to the motor strip in the brain. So that's where movement in your brain is kind of centered. There's different places where vision is kind of centered and hearing is centered, and balance and all kinds of, there's different parts of the brain for speech and all different kinds of things that are going on up there. But there's this motor strip, and the motor neurons are connected to that. So it goes from the motor strip of the brain. So if you have a brain injury or stroke, or plaques from MS in your motor strip, that can affect the motor neurons. So the upper motor neurons, the body of the cell is within the brain. So the motor strip sends a message to the motor neurons to move, and those are the upper motor neurons. The lower motor neurons, the body of those cells, are in the spinal cord. The upper motor neurons will send a message to the lower motor neurons. And those messages are all sent through chemical reactions. We often talk about it as electrical charges, and the chemical reactions, they're positive and negative. So they do have this chemical component, but it's really a chemical reaction to send these messages. So it's not like talking to your nerves, but it's this chemical reaction. The upper motor neurons work on glutamate, and the lower motor neurons work on acetylcholine. So these chemicals in the nerves are a little bit different. And that's what causes where the cell bodies are. And because of these chemical reactions, that's what makes the upper motor and then the lower motor neurons work differently. So the upper motor neurons result in very spastic, quick action kinds of movement. The lower motor neurons make the muscles very flaccid, so they just don't respond. They're just kind of limp muscles. And the spastic muscles will tighten and contract to any kind of stimulus. The lower motor is just flaccid. So there's really two different sets of treatments that need to go along with these, different, but still the same. So it gets all very kind of locked into different kinds of issues. So the motor neurons usually stay in the brain. They travel down to the spinal cord, except in the issue of the 12 cranial nerves, the ones that control your eyes and your hearing. And there's a couple of upper motor neurons that actually go out into your body, but not very often. They usually connect to the lower motor neurons that have more control over your entire body. So it depends on where that injury is. Now, it's real nice to say that the upper are in the cervical and thoracic, and the lower are in the lumbar and sacral, but they cross over, and damage to one can affect how the others perform. So sometimes you have like what's called a mixed injury. You'll have some upper effects and you'll have some lower motor neuron effects. So once you get through all of that, then what does that mean? Well, what that means is that if you have that upper neuron injury, you're going to have more spasticity. And that is because the motor strip or the upper motor neurons can be affected, but those can also affect the reflexes that are actually built into your spinal cord. So your body's very much like a computer. Your nervous system's like a computer. You know, when you use your computer, you can do one task one way, like you can copy paste using the toolbar up at the top, or you can use the keys on the press certain keys on the keyboard to copy paste. There's always two different ways to do things on the computer. There's always two different ways to do things in your body too. So some things take over, some things are rudimentary. So there's some reflexes in your spinal cord that can be affected, the same as the upper motor neurons. And then inside the muscle itself, there are also some reflexes. So when the muscles have a reflex that stretches and contracts, because that's what your muscles do when you move. So when that feedback is not being given from the brain to move your muscles still have the stretch reflex in them and they want to move. So when you have that upper motor neuron, you get that hyperspastic contraction of the muscle because it's trying to do its job. So somebody just wrote in that when they first were injured, they had little to no spasms 4 years ago, but now they have a lot. And that certainly happens because spasticity changes over time. Spasticity after an injury, trauma to your spinal cord is in an accident, that kind of injury. You usually have 6 weeks of completely flaccid body. Spasticity doesn't start until about 6 weeks after the injury, and it builds and it builds and it builds over time. So it keeps becoming stronger because your muscles so desperately want that input from the brain. Now in the lower motor neuron, they're still not getting the input, but the muscles aren't having that stretch reflex. And so what happens is that they just remain just flaccid. They aren't receiving that same kind of message because the lower motor neurons are originating in the spine, not up in the brain. So there's that subtle little physiological difference that makes a huge difference in your body. So the question has just come by on the chat is that like neuropathic pain? Well, my friends, there's new information out on the horizon where the big three, neuropathic pain, spasticity, and autonomic dysreflexia, which are all controlled by the autonomic nervous system. There's a lot of research now that, gee, maybe those could be all treated with one thing instead of treating the individual outcome product, being the neuropathic pain or the spasticity or the autonomic dysreflexia. Instead of treating those as outcome products, maybe what we should be looking at is treating the autonomic nervous system as a one-stop shop. If we can get the autonomic nervous system under control, all these symptom problems will resolve. So they're doing a lot of work in that. And guess what? They're finding out that that's really working out great. So we have a lot of progress going on with that right now. Now, the lower motor neurons, because they are flaccid, it's a little bit of a different process for people who have that. Fortunately, the good news there is that the injury is lower in the spine. And so therefore you have a lot more functional muscles that still work lower down into the lower torso that can be activated. But for both, no matter what, activity is what the body wants. So movement is the primary source of treatment. Now, with electrical stimulation, people who have spasticity can have surface stimulation on the skin. The electricity passes through the skin and they can get the muscle to contract and relax, which is what it wants to do. That feedback is then going up through the sensory nerves and they're saying, hey, something's going on here. And so it all comes together through fruition. With the lower motor, you don't really get that stimulation through the skin. Aha. But there are a lot of treatments currently available, implants, where they can go put an implant and attach it to the nerve in the lower motor neuron, and you can get some stimulation. So some of the implants can take over that job. Now, there was a problem with some of the implants, not with the implants themselves, but really with the business model. So a lot of these implants came out, about 15 years ago, maybe 20 years ago now. But the issue was that the people who were trying to promote these wanted to get the biggest bang for their buck for their investors. So they put these huge prices because they spent a lot of money developing these. They wanted to get the return on their dollar very fast. And so what happened, they put these huge prices. Well, insurance said, we're not going to pay that kind of price. So what happened was they kind of went off the market, but they're rediscovered and they're being developed. And there's some implants for function for upper and lower motor neuron individuals that will be coming out in the next year or two. I mean, they're that close. It should have been this year, but I say a year or two because we've had the COVID and everything is behind. But anyway, those were just like ready to be pushed out, but now we have to kind of see how it all falls out. Phrenic nerve is electrical stimulation. Is it temporary or is it permanent? Usually people who have problems with their phrenic nerve will have an implant. It can be on the surface of the skin, and that can cause the diaphragm to work by stimulating the phrenic nerve. They can also be implanted. Now, for a while, they couldn't be because of the immunosuppression factor, but there's Dr. Anders who's developed a new technique quite a while ago that he can do it minimally invasive, which reduces that risk for people. So more people have gone to the phrenic nerve stimulator, which helps them get off the ventilator. Now, with that implant strengthening over time, could it strengthen that phrenic nerve to make it temporary or not as long a term, but maybe in 5, 10, 20 years, would you maybe need it later? Well, that is the goal. But we just have to see how all of that is going to play out. So again, so much in the work, but yet things are going. Let's go to some of the, does it make a difference on how long post-injury that these implants work? Actually, no. The issue is that you have to get the muscles built up to tolerate it. So if you're not using your muscles, with the lower motor neuron, you'll see them shrink down really, really quickly. And people get really skinny legs and they get a lower body because their muscles shrink up. But you can build those muscles up again with the upper motor neuron. Because of the spasticity that's contracting those muscles, they don't shrink down as quickly. But you still have to have your muscles to be strong enough to support your body for whatever activity that you want to have done. So these are the kinds of things, it's never just as simple as, well, plop this stimulator in. the nerve will work, and everything will be hunky-dory because there's always something else to work on. So in working with the Christopher Reeve Recovery Project, what we found was that we could get the muscles strong enough. We could get them to support body weight in the pool because the buoyancy helped. The biggest, in using the partial weight supported walker and the treadmill, that could work. The problem was in getting balance with the body. So balance is kind of a separate issue. You can provide that input, but with the new implanted stimulators, they're working better. So there's improvement in that regard. So there's just things that are going on all the time that's really, really helping. This leads into one of the questions that has come up about the baclofen pump and spasms. So there's a lot of questions about spasms. And again, that relates to the upper motor neurons and that stretch reflex inside the muscle. And so the first treatment for spasms is movement. Now, as that person wrote in, my spasms keep getting worse, and they will keep, sometimes it levels off, and sometimes spasms keep getting stronger because they're looking for that movement. So no matter what, movement is a key to this puzzle. So any passive range of motion that you can do, you're providing movement. If you can use a bike that just is passively moving your legs in that pattern, that provides movement. If you have um, a lower motor neuron, it provides that movement. Just it's stimulating the part of your body that's not getting any stimulation. If you are lucky enough to get electrical stimulation, and that is going to become, surface on your skin, and that's going to become more and more prevalent as the prices keep dropping. So insurance, it's been validated scientifically through research. Yes, in fact, this works, but it's so expensive that it's difficult for insurance companies to justify spending all that money on one person. It's complicated. Hence, we need to all be advocates for this kind of thing. So a movement is one thing. Even if your spasms are so horrific that you think, well, it's not really helping, it is really helping. So movement is the first thing. Then usually people get advanced to medications for spasms. Oral medications, they travel throughout your whole body. Anything you take in your mouth, anything you inhale, anything you eat, anything you drink, you rub it on your skin, you insert something into your body. There's always some consequences to anything that you put in or on your body. So the consequences of the anti-spasm medicine, the muscle relaxant, is it travels throughout your body, and people don't like that brain fog. Hence, the Botox has really taken over the Botox is really taken over because it's just stays locally in that muscle. It's an injection. It stays locally at that muscle, and the muscle will repair itself. So you have to keep having the injections over and over, but you don't get that brain fog. You don't get that limp feeling throughout your body where you do have sensations. So Botox has really become more of a go-to treatment than even the oral medications. The next level of things would be the baclofen pump, and that does use the drug baclofen. The pump is a little device about the size of a pacemaker for heart. It's just kind of a tiny device. It's put in the abdomen in front of your body, and a little thin tube is wrapped around your body, inside your body, into the canal where the spinal cord is. It does not go in the spinal cord because that would be damaging to it. So it goes in the canal where the spinal cord is hanging and resting in the cerebral spinal fluid, all cushiony in there. So what will happen with that is, what will happen to that is that the baclofen will bathe the spinal cord. Now, eventually the pump has to be refilled, so you have to go in and have refills. So These questions coming in are so good, it's distracting me, but that's okay. Keep them coming because I'm going to answer them. So what happens is that your body relaxes. You have a test that's done before the surgery and the implant, so you know if it works or not. The good thing about this pump is if you also have neuropathic pain, you can mix the baclofen and the pain medication in the pump. It stays in the lower part of your body, so you don't have the pain medication side effects. So backing up just a little bit to the Botox, does it have side effects? For a few people, it does. It has had some side effects for some people where it travels around in your body, affecting other parts of your body, but that is so very rare. Some people get some redness or some irritation. Some people just can't take it because, you know, we're all unique beings. But for most people, the side effects are really few and far between. It is a trial and effort kind of period of uh, it's a trial and effort kind of period to get the right dose for you. So the first dose you have might not do very much good, and then you have to wait to have the second dose because everybody metabolizes differently. So, you know, those kind of things, you know, are just, you know, the way healthcare is really for anything, you know, how much pain medication. Some people need more, some people need less. Botox is used for lots of things. It's used for a spastic bladder. It can be used anywhere where there's spasms. Um, if you have spastic vocal cords, it has been used in the vocal cords. If you have migraine headaches, it's injected into the scalp and just under the skin to the muscle at the back of the head and relieves migraine headaches. Oh my, it sounds like the cure for everything, isn't it? It's certainly not for everybody, but it certainly can be helpful as well. There was a question in that somebody had written in earlier about um, effects of gabapentin, which is pain medication for neuropathic pain. But while we're in this autonomic nervous system, let's talk about that. Have I ever heard of that affecting somebody's bladder? Yes, it is a side effect if you have a spastic bladder. Um, and I think the question was, can it make your bladder incompetent, meaning that it won't hold urine anymore? Well, yes, and one of the main side effects, the big side effects of gabapentin is that people have difficulty with their vision. And the reason for that is the muscles that control the eyes are smooth muscles. Guess what? The muscle in your bladder is smooth muscle. So you see, if you take gabapentin, you get on a high dose, can affect your eyes. Can it affect your bladder? Yes, it can, because the bladder muscle is so much bigger than the little muscles by your eyes that people don't have that much problem with it. But yes, gabapentin can certainly affect your ability um, for bladder control. So that was one of the questions about that. Yes. So if you take gabapentin, you find you're having incontinence or there's some change in your um, urinary system, you can try pregabalin, Lyrica. Or you can try some of the other oral medications that will help neuropathic pain, which are usually the anti-seizure medications. And people say, but I don't have seizures, or the antidepressants, and people say, I don't have that, but it is a side effect. Control of neuropathic pain is a side effect of these medications. So they give you a little tiny dose, not enough to treat depression, not enough to treat seizures, but a little tiny dose. Now, if you do have depression or seizures, people who have that as well as spinal cord injury find that they have less spasms and depressions because they're on higher doses of those medicines. So it doesn't come up as frequently if you already have that. It's kind of a side effect, but you know, not all side effects are bad. Some are actually good. And that's an example of a good one. Here's another lady. A husband writes in that his wife's 65 and for 5 years she's been quadriplegic and she has a terrible time with extreme sensitivity on her bottom, and sitting in the wheelchair is very difficult. This is not that uncommon of a problem. I have heard of this a number of times. It's not something you hear every day, but it's something that comes up quite frequently. Now, this is the good news, is that if there's some kind of sensation of uncomfortableness, pain, neuropathic pain, those are actually good news symptoms, because it means some kind of message is getting through. It's not getting through in the correct manner, but there's a message getting through. If you feel something, if you're C5 quadriplegic and you feel something in your bottom, there's a message getting through. So, that is good news. The bad news is it's so darn uncomfortable. What do you do about it? So you can try, we don't know if the sensitivity is coming from spasticity or if the sensitivity is coming from neuropathic pain. I would suspect more neuropathic pain. There's some things that you can try mechanically outside the body. If you're on a foam cushion, you might try a Roho cushion. If you're on a Roho cushion, you might try a foam cushion. There is a cushion out there. It's more expensive. It is more dynamic because it has movement. Some have movement in two sides. So the cushion, much like an air pressure mattress that changes the pressures, the cushion will move on two sides. Some has 4 chambers and they will move. And so there's constant movement in there. So you don't have the pressure that's going. So if you can talk to your vendor and try some of those cushions and find one that helps, then you can talk to your healthcare professional or your therapist and say, this cushion really worked. Could you write a letter of medical necessity and say, we've tried it, we've had success with it. So that really helps a lot too. Let's see, the non-compliant bladders. So there was a question that popped up about that. How long does it take to repair that? So let's talk about the bladder. There's a lot of questions, different questions about catheters with crustaceans on the catheters, suprapubic catheters. There's always questions about, and today in particular, there's a lot of questions about catheters. So if you have a spinal cord injury or you have some kind of problems with your bladder, you should have a urodynamic test every year. If you have no problems with your bladder, you really need a urodynamic test every year, because it's not like the bladder will suddenly signal to you there's a problem here with pressures, or your bladder suddenly become non-compliant. Why is that? Well, if you have urinary incontinence, that is a clue. That one person wrote in that they were having troubles with the catheter and getting deposits on there, and they were having to change the suprapubic every week instead of every month. Then the urodynamic test will indicate what situation is going on in the bladder. So why do you need one if you're not having any problems? Because you need that baseline. If you have a baseline and then the next year, and it says everything's going great. How wonderful is that? So you have your baseline, you go back the next year and it says, oh, you're having some increased pressure. They'll know that because they can compare it to your baseline. So they can home right in on that. Zoom, they know exactly what to do for that. If you're having a problem and you don't have a baseline, they have to delve a little bit deeper. They might need to do more testing. As long as it's like knowing your baseline blood pressure, then if it's elevated or if if it's gone down a bit. It's always helpful to know your baseline, because the bladder is such an important organ. It's a protection outlet valve for your kidneys. The kidneys are always processing urine waste from your body. It's waste. The kidneys process it into urine. The kidneys are processing organs. They don't store anything. The waste runs down your ureters from each kidney and it goes into one bladder. If there's a problem with pressures or clogging in your ureter, or something's happening in your bladder, or your sphincters are suddenly out of whack, and these things come on, it doesn't start from day one. It comes on gradually, kind of like spasticity. And most of the time the source is spasticity in the bladder, or the sphincters are spastic and the bladder's contracting and or filling, and the sphincters are closed tight. And so where's that urine going to go? It's going to go back up into the ureters, and it's going to go into the kidneys where there's only delicate kidney tissue. There's no room for storage. So what's going to happen is it's going to damage that kidney, and eventually kidney damage can lead to kidney failure, and then we're really in trouble. So always get that urodynamic test. It's just very important to do that. So can I recommend different products? Well, I can't really recommend any particular product because I don't know you as an individual, and everybody really needs to have their own individual product that's unique to them. But be sure and work with your physical therapist. Know the different kinds of products that are out there. You can go on the internet and just kind of look around at seat cushions and see if there's something. I know one person that had such sensitivity, hypersensitivity when they were sitting. It was just such an awful problem that it just practically destroyed their lives. It was just so horrible. And I think about the husband that wrote in about his wife. So I'm very sensitive about this because it was a family member. And so I've lived this experience, not myself personally, but I've lived it through a close family member. And I know that finding that cushion that really helps. Also, cushions do not eliminate pressure injury. There's no cushion out there that can eliminate it. No matter what cushion you have, you still need to do your pressure releases. If you have a power chair and you can tilt back and forth, you need to be doing that. Yes, you're sitting up, you're in a meeting, you're at school, you're at work, you're doing something. I don't want to be laying way back in my, you have to do it because that is what's going to help remove that pressure from your rear end. It will prevent pressure injury, but also if you have discomfort, you just have to be doing it. If you don't have a power chair, you've got to be doing those pressure releases, pushing up on the sides of your chair and raising your body and getting that pressure off there and holding it up there. And you need to be doing that really every 10 to 15 minutes. You'll see that cushions are pressure dispersing. They never say they will eliminate. If somebody says it eliminates pressure injury, they're false advertising. They just don't. If you have a chair and you can lean side by side, if you have the proprioception that you won't fall over, or if you can lean forward without going head first over in your wheelchair, all those are important things to do. If you sit on the commode or on the toilet, you're not excused from that pressure release. So it still has to be done. So that's very important. Now, this person wrote in and they have a power chair and it has no power. It gets stuck someplace. So they want to get a stronger motor on their chair. Now that might be the necessary thing, but if you have a power chair and it gets, not all chairs are made to go through the grass, but if it gets stuck going to the mailbox, it could be the way you're hitting the curb or something. If it is so weak in its mobility that it can't do normal everyday kinds of things, you need to talk to your vendor. Maybe there's something wrong with that chair. The reason why a vendor might not put a stronger motor on a chair is maybe the chair is not built for that and won't take that kind of power. Maybe the structure of the chair is lighter weight and it won't take that. Or it could be your payer. You might need to talk to your healthcare professional about a letter of medical necessity to ask your payer because of your unique needs. That is a couple of ways around that. But there's a lot of reasons. I know a lot of people have asked me about, my vendor won't do this and won't do that. First of all, they have to have a medical order to do it. Second of all, not somebody will have a frame of one kind, but they'll want a motor or wheels of another kind, and that frame will not handle that kind of equipment that they want. So sometimes it's a mechanical kind of issue. Sometimes you always have to have an order from your physician. You can't just say, I want a different motor. These are all prescription devices. So there's some different things that might work for that. Now, here's a person that's had a Foley catheter and they've got that blockage of urine that's coming. I also want to add that onto urodynamic testing. You also need to have that bone density screening. When you're not putting weight through the bones of your body, the calcium tends to leach out of them. Some people think, well, I'll take some calcium pills and I'll put it back in. It doesn't work that way. It works that way for some things, but it doesn't work that way in this particular case. The bone structure is changing because it's adapting to uh, the spinal cord injury and not putting weight through those bones. Just about everybody now. Different people say, well, I tried to get one and I couldn't get one. But just about everybody, even if you're on Medicaid or Medicare, you can get a standing frame. If you don't have one, you should ask your healthcare professional to order you one. A lot of people, a lot of payers will pay for a standing frame. If you can get one, if you have arm function and can get one with gliders, when you move your arms like skiing, it will move your legs. So that gives you that motion, that feedback to your legs, help your spasticity. But get a standing frame. You'll need to learn how to use it. You'll need to build up to 1 hour a day of standing in your standing frame. You need to talk to your healthcare professional. Not everybody can immediately do this. If you've not had a bone density test, and you've been injured for a while, or even some people in a short amount of time, when you do the catheterization, you see that white stuff coming out and people say, oh, I have an infection, but sometimes it's not. Sometimes it's sediment. Sometimes it's calcium that's being eliminated from your body because it's leaching out of your bones. So these two tests are very important, the bone density test and the urodynamic. They're very important because your body's changing, but you're not getting any message about it. If your bones become too soft, you can have osteopenia. That's like beginning of loss of bone density, or osteoporosis. It's not just a disease of old ladies. It's a disease of people who have spinal cord injury as well, because they're not putting that weight through their bones. Now, if you get the standing frame, this does not mean that you need to stand up in it right away. You need to check to make sure your bone density is good. You don't want to put weight through your bones and they can't handle it. You want to check to make sure you don't have a blood clot somewhere in your legs. So you need to have that healthcare okay before you start this. Now, there's a little clause in just about everybody's insurance policy, and that is that you get 2 weeks of kind of a refresher. It's usually for mobility training. You can get that 2 weeks of therapy. Sometimes it's inpatient. That's pretty rare. Most of the time it's outpatient, but you can use that to test out different kinds of equipment, like a standing frame, learn how to use it. You can try some of that electrical stimulation, learn how to use it. There is some evidence that's coming out now that people that, oh, we have to buy these big expensive bikes and we have to buy there is some evidence that those little nerve stimulators that they use in just about every therapy, that is providing some feedback as well. So hey, why not? They're a lot less expensive, and insurance will probably maybe pay for one. I'm not the insurance company. That's up to them. But because it is so much less expensive, your odds are a little bit better that you might get that. So that crusty stuff that's clogging the catheter, that could be a variety of things. There's also a question about bladders and urinary tract infections, and how can you avoid those? And drinking fluids help. Now you're on a bladder program. Linda, I can't drink fluids all day. If you have a suprapubic or you're using some other kind of catheterization program, you might be able to drink more. Somebody wrote in, I heard if I squeezed 4 lemons and I drank it, that would work. Well, if there's no sugar in it, some people will say cranberry juice works good, but it has a lot of sugar in it. So people then switch to cranberry pills. Then they did research and they found out that there's no effect of this whatsoever. But if you want to try lemons, not lemonade full of sugar, but oh, a mouthful of 4 lemons. Ugh, that sounds like an awful, painful, sour kind of thing to do. There are some things you can buy just at the store, at the drugstore. You can order them online called pH strips. Do you remember back in high school when you test things? Are they an acid or is it a base? And you want your urine to be just tiny bit slightly acidic. That's its normal. Um, that's its normal range where it should be. And then test periodically, take a little test strip and test. You need to test fresh urine, not urine that's been sitting in your leg bag all day. But test some fresh urine and see if there's something that you're drinking that's helping, if the pH is going up or going down. I know in doing this in the hospital, because we used to do it all the time, people have kind of gotten away from it. But we used to test pHs all the time and try to do different things, drinking more or changing their fluids, like alcohol, sugary drinks, very bad for the bladder, very bad for promoting diabetes, which is a secondary complication of spinal cord injury, again, because of not using those long muscles in the thighs. So check that alkaline of the pH and see if there's something. You don't want to get it down real low. You don't want it to be acid. You don't want it to burn your bladder lining. You don't want it to burn your urethra. But see what your pH is, and then see what you can do to get that down. Water is usually the best things. Caffeine and alcohol is very dehydrating. Sugary drinks puts a lot of sugar in your bladder, and guess what? Bacteria love sugar. They feed off of it. So if you're eating a lot of sweets, and yes, that affects your urine as well as your bowels. If you're eating a lot of sweets, if you're drinking a lot of sugary drinks, all of that will affect your bladder. So look at your diet, look at your fluids, and see how you can, because everybody's metabolism is different. I can't say you need to do exactly this and your bladder will be just fine. Everybody's is a little different. So you'll need to kind of look at yourself and see how that works out. So again, a standing frame. Do I recommend any particular kind? No. Standing frames work pretty much the same no matter. You want to look at the padding that they have, because they have blocks for your knees and blocks for your hips. If you have a higher level injury, you might need a block for your upper chest. That's so that your joints don't when you stand up, but it holds you up in space. So look to make sure that those padding is really nicely padding. Again, you'll have new pressure areas on your knees and maybe around your abdomen where you never had those pressure areas before. So you need to check your skin. You don't want to go up there. Well, this isn't bothering me. I'll just stay in this for an hour. Well, I'll stay 2 or 3 hours. No, because you could be developing pressure sore. So you need to build up your skin tolerance to doing that. Okay, well, we're coming down to the wire here. And traditional Chinese meds, I saw this come up earlier. So what traditional Chinese medications help? That I do not know. I worked with a doctor in Seattle who was Chinese, and he provided a lot of Chinese medicines to his patients. And it was very interesting because when the people would come into the hospital, there would usually be trouble because we didn't know about the Chinese medicines. And so we would give them Western medicine and they would interact. Or maybe he was doing a Chinese herb that was affecting their blood pressure. And then we would come in and give them blood pressure medicine. And then again, there'd be huge problems. But this guy was really cool. And so he involved us all in this. And so we were able to balance that out. So whatever you decide to do to help yourself, if you decide to take some Chinese medicine, if you decide to go into herbal remedies, if you get a dietary supplement at the grocery store, no matter what you decide to put into your body, check with your doctor, check with your pharmacist to make sure there are no interactions. Oh my gosh, there are so many things that can interact with each other. It's just amazing. But the great thing is they have a computer problem. They can put in your medicines, they can put in this new supplement that you're taking, or some of the programs, not all of them, will have the herbal medicine. They might want to know what specifically is in the herbal medicine instead of this is my specialty. They'll need to know what's in this, what products are in there, and they put it in the computer and boom, there it is. So it's not really a lot of effort on anyone's part. It's really up to you to protect yourself from yourself. And I know, people go to the grocery store, well, here's some vitamin K, and I heard that was good, so I'll take that, but that interferes with blood thinners or even baby aspirin. So you want to be careful about what you really put in your body and really know about it, and check with your healthcare professional, because the last thing you want to do is harm yourself, thinking that you're helping yourself. So always, always, always check, even if it's something that you're rubbing on your skin that has any kind of medication component in it. You want to tell, I use Benadryl ointment or something, cortisone ointment, which is a steroid, which can affect a lot of things. It's still leaching into your skin. If you're using any over the counter kind of product, or if you're taking any street drugs, tell your healthcare professional, because if you're using the CBD products, that can interact with some of your medications, or if you're just smoking marijuana that you're buying at the street corner, that can interfere. If you're taking your wife's narcotic prescription, that can interfere with your medication that you're taking. So you want to protect yourself from yourself, and just make sure that you double check, double check, double check. Now, I know I didn't get to everybody's questions, and I know I didn't get to a lot of the questions that people have written in, but I hope that it was global enough that a lot of people have gotten information that they needed from the cumulative whole. I do want to mention that on Monday, February 1st at 2 p.m. Eastern, Dr. John, who was with Christopher and Dana Reeve Paralysis Foundation, and I are doing a webinar together about adjustment issues and those kind of things. He's a psychologist, so he has some different information than I have. And so I think it's going to be kind of a neat pairing to see how that goes. So if you have time, be sure and look that up and join us. But I thank you so much for coming today. It's really been a good lesson. I hope I wasn't too distractful. Thank you, Eric, for that kind remarks. And the link to Dr. John has just been put on there to that webinar. So that'll be great. And I hope to see you on Monday. And if not, I'll see you next week. Don't forget, Wednesday nights, tonight, I'll be on the community. If I didn't get to your question, please feel free to write in or write in anytime. So Wednesday nights, that's when I'm there. Thank you so much for coming.